Thanks everyone for joining. So I think I know most of the folks on this call. My name's Ben Weston. I'm an associate professor of emergency medicine at the Medical College of Wisconsin in the division of EMS medicine. I'm the medical director for the Office of Emergency Management at Milwaukee County, and then also serving as medical director for the COVID-19 Unified Emergency Operations Center for the city, county, and municipalities. For the sake of time, if people don't mind, just instead of doing introductions, which will take forever, to just write your name, your title, and your organization in the chat box, that would be great. So basically, I'm going to go through kind of measuring disease burden, what we've seen for national trends so far, talk about the SAFER model, how it applies to Milwaukee County, next steps, and then certainly some time at the end for questions. I think we should be through the main part of the presentation in probably 20, 25 minutes or less. So I'll go through. You can feel free to throw questions up on the chat. I have two screens open, so I'll try to follow the chat here with questions, but also you can unmute yourself at any time or certainly with the questions at the end and ask a question as well. All right, so how to measure disease burden. I think in the media, what we see most often is number of cases. So we hear that, the state of Arizona doubled their number of cases in the last, I think it was 2 weeks of what they've seen all the way up until that. I think it's the number that certainly is most dramatic, is the easiest for the public to understand. But as we've heard discussed from a national level on down, it is affected by testing. We know that the more people you test, the more cases you're going to find. Contrary to what some of the discussions have been, you certainly aren't creating cases by testing. You're not creating more disease. So testing is critical, but it does throw off your cases number. And so if, County A is testing everybody, they're going to find a lot more cases than County B, who's testing nobody, even if they have the exact same burden of disease. So cases is a tough number to wrap your head around, especially when you're trying to figure out resource allocation. Reproductive number, I think, is a very appealing number. If your reproductive number is 1, that means every person, in theory, passes it to an average of 1 person. So you're not really having a growing number. You're not having a decreasing number. When your reproductive number goes below 1, you're passing it to less than 1 person, and the amount of disease is going down. And when it's above 1, it's going up. It was a very useful number, especially in the beginning of the pandemic, when was fairly constant. But as testing ramps up, the reproductive number has some of the same challenges as cases. More cases mean a higher reproductive number, so it makes it very challenging to really understand what's going on.
Can you put a game outside for somebody to pick up?
What time? I'm on a conference call. Are they coming now?
And if you guys don't mind,
that's okay. I'll just start. We can't do it right now.
That's okay.
Don't mind muting your end there. Sorry. And then, so there's hospitalizations and deaths. So hospitalizations and deaths are definitely true numbers. They're not like cases where they go up and down with testing. If you have COVID and you get sick, you're probably going to be hospitalized and certainly may die as well. And so those are true numbers, but the challenge there, of course, is they're lagging numbers. So it takes a while for them to rise. That's especially the case now that we're seeing a decrease in age of COVID-19. So in Milwaukee County, for example, the average age in March was 56 years old. The average age in June was, or 52 years old. The average age in June was 36 years old. So almost a 20-year age drop over a few months. And so younger people are less likely to be hospitalized and they're less likely to die. It's not necessarily a good trend because young people don't live in isolation, but nonetheless, they're troublesome metrics to follow. So that really leaves percent positive, which is about as good as we have at this point. And it is helpful. So if 100 people are tested and 10 of them are positive, you have a 10% positive. It's fairly independent of testing. The more you test and the more wide a sample you test, you're probably going to drive down your percent positives because presumably if you're doing less tests, it's of more symptomatic people, hospitalized people. But nonetheless, it's fairly independent. It's at least more independent than cases on testing. But we know that percent positive is affected by testing rates. And so that's what we'll talk about here. So percent positive versus testing rates. Hopefully you can see my mouse here. It looks like you can. So if we're comparing, and this data is about 3 weeks old, so don't pay too much attention to the specific numbers. We'll get to updated data in a minute, but it kind of illustrates the idea. So if you look up here at the blue group and the green group, So the percent positive is the same, it's 0. Nobody in these census tracts has tested positive for COVID-19. However, in this blue census tract, we've tested 12 people. And in this green census tract, we've tested 141 people. So up here in the village of Bayside in this census tract, you can be pretty confident with 141 people tested, there's probably a relatively low disease burden. It'd be nice to have 1,000 people tested, but you can be pretty confident. In this blue group, it's hard to know what to do with 12 tests. It's even harder to know what to do with 5 tests. And so percent positive is the same. Interpretation of the results is going to be very different. And on the flip side, you see this yellow census tract and this red census tract. So both are around 20%, 18 here, 25 here, but similar percent positives. But again, here you've tested 28 people, whereas here you've tested 105 people. So you can be a lot more confident in your percent positive in the red group than your yellow group. Certainly your yellow group seems concerning, but you'd want to test more people to really understand what's going on in that community. And this map in the backdrop, for those not familiar, is part of our county dashboard that shows the percent positives. So the dark purple, high percent positives, the beige color, low percent positives. And over here, we can see again, the green, blue, yellow, and red, how they line up with testing density, and so, or testing rate. So again, the purple, very highly tested, the orange, very low testing. So ideally, we'd want to bring these two together and understand how they interact with each other. And that's where this model comes in. So basically, it's a 4-quadrant design. Initially, we were trying to think of it as giving a score to each community or a number to each community. So we could just put them on a line, who's highest disease burden, who's lowest. Played around a lot with the numbers. You can't really relate testing rate and positivity in a linear way. It really has to be in this 2-dimensional way from what I found looking at this 4 quadrants. So the high concern area, the red area, it has a high testing rate and a high positivity rate. So a lot of tests are being done, and you're seeing that there's a lot of disease in the community. This is a high concern community because you know there's a lot of disease there. You come down to this yellow group, and you're noticing high positivity rates, but you're not testing many people. This is certainly a concerning community, but it's being under-tested because you're not doing enough tests to really understand how many people in the community. Because even if you're doing very few tests, a lot of them are coming back positive. So this is a community where you really want to focus on testing. The blue community, low testing rates, low positivity rates, it's just really hard to say. It's undetermined. If you do 5 tests and none of them are positive, I don't know what to make of that. Did you just choose the wrong 5 people? What does it mean? Highly resourced, this is where you're doing a lot of tests. So consider that Bayside community. You've done over 100 tests, every single one of them is negative. Probably doing, now granted you may need to shift who you're testing, maybe you're not testing the right people, but as a general assumption, this is probably a community, if you had to live in one of these 4 communities, this is probably the one you'd want to live in. There's lots of tests being done. There doesn't seem to be much COVID going on. So this is again how our 4-quadrant design relates to those 4 groups that we talked about before on the map. So this is what the model looks like. There's a lot of detail here. I won't talk about it altogether, but I can send this out to the group, or this was sent out to the group. It was attached in the invite, but happy to send it out again. So basically, again, you have your red group, high concern. So it gives a summary of what's going on. Testing, you want to continue that high level of testing, what to do with resources, and maybe how to address messaging. Under-tested, same thing, summary, what to do with testing, in this case, increase it aggressively, what to do with resources, and what to do with messaging. Undetermined, this doesn't seem to be a community that's quite as concerning as these two, or at least not as urgently concerning, but we just don't know. So it's still a community in need of testing to really understand what's going on. And then our green community, now in a situation where you have finite resources, which really is pretty much every community right now, you're going to probably want to think about shifting some of your resources from your green community over to your red community. The red community is really one that it may need more testing, but it's getting a high level of testing already compared to the rest of your community. What it really probably needs at this point is resources, tracing, isolation, support, finding out why this disease burden is in this community, understanding what equity issues exist in that community. Whereas this yellow community really needs testing. And so you may want to shift testing from the green communities over to your yellow community. Now, if you have infinite resources, then keep it right as it is in the green community. You're doing great, and then bring more resources into here. But we know most communities have finite resources. There's only so many people who can trace. There's only so many isolation facilities. And then there's a few key points here that we'll talk about as we go on. So cut points, to get into some of the details, cut points are going to be really important. So where do you cut off low testing versus high testing, or low positivity versus high positivity? So when we put this together, we looked at 3 different ways to do cut points. So one is median value. You just take everybody who's been tested, say you're going from 0 up to, well, let's do positivity. Those are easier numbers. So 0 positivity up to maybe 30% positivity. If your median value is 10%, then you place 10% right there. You force everybody into different groups. So the nice thing about median is it distributes the groups evenly. You can do cluster-based. So there's something called Jenks cluster-based classification. And basically what Jenks does is it looks at a large group of values, and it tries to put those that are most similar into the same group while having as much dissimilarity between groups. One's a little harder to understand. The next slide will clarify it a bit more. And then you can certainly do goal-oriented. So if you say we want less than 5% positive, you just put your goal right there, 5% positive. We want, 2,000 tests a day. You put that here as a rate, and you can cut it off that way. So this shows how those break down. A lot of numbers here, a lot of things to digest, but basically I think the take-home points are, if you do median value classification, it splits the groups pretty evenly. Okay, we have the same number in each of the quadrants. So it artificially separates them into groups. And you can see down here, median value, it doesn't care, it splits. So you can see right here, for example, these 2 groups are pretty much the same, but it split them into 2 different groups. So it does artificially split the groups. If you look at this cluster-based, it does a better job. It uses formulations to figure out which groups are most similar. So it makes cut points in places that make the most sense for the data. And then goal-oriented is obviously artificial as well, because you're assigning the goals. And you can see how goal-oriented splits up our groups. We'd love for everybody to be less than 5%, but they're just not. And so it ends up with a pretty uneven distribution. But these can each be helpful in different ways. I think median value and cluster-based classification are going to be most helpful on the day-to-day or week-to-week usage to distribute resources, whereas goal-oriented is probably going to be most useful to see if you're reaching your goals. So for example, in Milwaukee County, we can see we're doing okay for positivity rate. It's pretty well split, but we're not doing as great as we'd like for testing. There's really only 2 communities that hit above our testing goals. So this is normalized for our testing goals in Milwaukee County. And so here's when you put it into a map. So this is a map of Milwaukee County. Again, this data is about 3 weeks old. We'll look at updated data in just a minute and kind of compare. Again, this is a reminder. You have your green, red, yellow, and blue categories. And this shows when you break it into median value, cluster-based classification, and goal-oriented classification. So it might be easiest to start over with goal-oriented. You can see pretty much every community is put into this blue or this yellow. Again, I think this might be useful to look at on a weekly basis to understand, are you achieving your goals? And your goal under the goal-oriented is really to push everybody into green. With your cluster-based and your median, they're naturally going to be split up. So everybody might be in green for goal-oriented. They'll still be split up for these 2 because you're artificially splitting up the groups. But it gives you a good idea of where the clusters are. And one might be more useful in a community than others. So in this case, I think probably the median value proves more useful because it just separates out the groups more for this point in Milwaukee County. Whereas the cluster base may prove more useful in the future. So jumping to the future. So when we look at Milwaukee County, we can look at each map and how it's changed over 3 weeks. So again, probably easiest to start with goal-oriented. I think if anything, this has gone in the wrong direction for Milwaukee County. And I should say we've seen that everybody's aware nationally things are going in the wrong direction. When we look around the state, things are going in the wrong direction. So I think this shows that in Milwaukee County, even though our positivity rates haven't seen huge jumps, we can see on a municipal or a census tract level, we have a lot more yellow now than we did 3 weeks ago. So we have a lot more under-tested communities by our goals than we did 3 weeks ago. When we go into cluster and median value, I think we're seeing similar trends and similar clusters. So Not surprisingly, the south side of the city of Milwaukee, or the central part of the county, in both cases is in the red. This is our largely Hispanic community, which we know is definitely a community of high concern. There's a lot of testing going on there, but there's very high % positives that we're seeing. What I think is interesting as we look from 3 weeks ago till now, and same here, certainly with the cluster-based classification, 3 weeks ago till now, you see a lot more yellow in the central part of the city of Milwaukee, the north part of the county, in what's predominantly an African-American neighborhood, a neighborhood and a community that was hit very hard in the beginning of the pandemic for a whole lot of equity-related reasons that we can get into another time. But they were hit hard in the beginning of the pandemic. Really no reason to think they wouldn't be hit hard if we start to see an increase coming up again. And we do start to see that reflected here. There's a lot of yellow all throughout here, which means it's really a community that is, we should be very cautious of. It's probably being under tested. There seems to be high positivity without a whole lot of testing going on. And then we do see more green communities emerging in both areas, especially on the outskirts of the county. So as we look from here to here, and then also in our median, we're seeing a lot more green on the outskirts where—
Hey, Health Department, this is Heather.
where a lot of, oh, I think Heather, you need to mute yourself. Where a lot of testing is being done,
1 moment.
but not a lot of percent.
But go ahead.
Coming through.
So I was like, I've developed a whole sheet to keep myself more organized with this. So, all right. Yeah.
Whoever
right,
Heather is on the phone right now, if you don't mind muting yourself. All right.
So forcing. I can hear your conversation in the room.
All right. So anyhow, a lot more green on the outskirts, high levels of testing with low levels of positivity. So some suggestion of shifting testing resources. And then the blue seems to be going away more. So we have more communities shifting into more defined areas, either highly resourced or under tested. So hopefully this, I think, can help to guide Milwaukee County in distribution of resources. So for example, right now, each census tract gets, or each municipality is told they're supposed to have X number of tests per week. But perhaps it should be thought of more on a county level because certain municipalities maybe don't need tests as much, whereas other ones certainly are more in need. So just to wrap up, next steps, I think one is community use. We're gonna try to get this up on our county dashboard. It takes a little more finagling just because it's not a typical, color pattern or map to get up, but hopefully in the next couple of weeks, we'll be able to get this up, potentially even updated daily, but certainly weekly on our county dashboard to understand what sort of trends we're seeing. Validation of the model is going to be helpful. In theory, I think it seems like it'll work, but of course, who knows if it'll work until it's applied to a community. And then I think certainly thinking beyond census tracts. Census tract seems to be the most natural way to illustrate it and to understand it, but there's no reason you can't plug long-term care facilities into this, or plug different races or different ethnicities, different age groups, and understand what other disparities are occurring in the community. All right. I want to acknowledge 3 folks from OEM that have been really instrumental in helping move this forward. Zach Swingen is our GIS specialist who is really everything behind the dashboard. It's all manipulation by Zach and his folks. So he's done an outstanding job there and helped to put the maps together. In order to put the maps together and put all this together, Shannon Grumman, who's our OEM Office of Emergency Management Data and Analytics Manager, who churns through all this data and makes it look nice and hands it off to Zach to make it look nice on our display. And then of course, Dan Pojar, our OEM EMS Division Director, who helps to oversee all the administrative end of these efforts. So thank you to all them. And we're at 20 minutes. So I will minimize this and pause for any questions. And to be honest, a lot of names are mixed up in the chat box. So if you have questions, feel free to unmute yourself or type it in the chat box now. All right, well, seeing no questions, I thank everyone for joining. Are there any other counties, so Dr. Hargarten, are there any other counties in the US doing something similar? So I don't think so. So part of the reason we worked to develop this was that I think just about all of the models that I've seen are using, most are using either number of cases, a lot of them are using cases per capita, so number of cases per 100,000 residents, but they're still very dependent on testing. Some are using percent positive. I think it's just a harder number for people to maybe wrap their head around. So percent positive isn't used as much when you see maps laying out what the burden of diseases in different communities. But I have not seen any that are using percent positive and testing rates pulled together. I see a message from Aaron Sapinski in the mayor's office. How are health officers looking at turning this into action? Well, I can't put too much pressure on the health officers because they haven't really seen this too much yet. So I'm certainly going to distribute this to them. And I hope we as a county can start implementing it and thinking about resource management in this way. How can we get more info, technical data about the technique from someone in Cincinnati? Dustin Calhoun. So certainly we'll send out, can send out this recording, send out the slides, the detailed piece, and then we are working to publish this. It's under consideration now. And so once it's published, it'll have all the technical details on it, and we can certainly send that out to this group as well. From Dr. Swain, would it be correct interpretation to say that at the moment, we are not doing nearly enough testing in Milwaukee County, and also there's a bit of a maldistribution of tests such that there's under testing in less affluent parts of the county? Yeah, I think that's absolutely true. It's been one of the challenges, and I know there's a lot of folks on here from Milwaukee County that share in this challenge. Getting people to get tests has been really hard. I will say there's a lot of capacity for testing in Milwaukee County at the National Guard sites as well as at our health system sites. I would say we are not even using 50% of the capacity that's available. But the challenge is getting people to actually get out and get tested. And when we look, and Dr. Swain, this has been influenced by the numbers you passed along, when we look at symptomatic individuals, we know there's people out there with symptoms. We're at a low time of year for influenza-like or cold-like or COVID-like symptoms, but we know there's lots of people out there who have symptoms who aren't getting tested. So that's certainly a responsibility that we're trying hard to message, trying hard to decrease any barriers we can to people getting tested. But I think that's exactly right. I think we need to do more testing. And I hope that with this model, we can target our testing and our messaging and our resource utilization a little better. Dr. Cancel Martinez from UWM, in addition to testing, what additional resources should communities look for areas of high concern? Yeah, it's a great question. So I think of it as separating out those red communities and those yellow communities. So the yellow communities, remember, are having high percent positives, but low testing. So you're not really doing that many tests, but when you do them, you're seeing a lot of positive people. I think that's a community that at the moment is most in need of just ramping up testing and figuring out what's going on in that community and ramping it up very aggressively and very rapidly. You take that as compared to your red communities, which are getting a lot of tests. So in Milwaukee County, this is largely our south side of the city of Milwaukee. There's a lot of tests going on there. And in our community, that's thanks to the UMOS testing sites, thanks to 16th Street Community Health Center, lots of testing going on. But we're seeing really high positivity rates, like 30% positivity rates. So in those communities, I think we need to continue the high level of testing to find out who has COVID-19, but I think it's really about resources at that point. So it becomes the resources we're talking about are certainly contact tracing, isolation opportunities, quarantine opportunities as well for people who may be exposed. And then also resources as far as investigational resources. Why is that community being more effective? What community leaders, what community groups can we reach out to touch base? How can we message better into that community? Things like that. And then of course, understanding equity concerns. So in Milwaukee County, why is our Hispanic community seeing a high number of cases? Why is the central part of our city seeing lower levels of testing? Greg Stadler from the Milwaukee Healthcare Partnership, how often would you recommend rerunning to keep targeting the right communities? It's a great question. I don't know that I have a perfect answer to that. I think it's a lot to take in to do it every day. But it does average the last 14 days, so you won't see major swings. The way we did it, it averages the last 14 days. I think doing it weekly at least would be important to understand, because that's, I think, enough time to see fluctuations and to kind of set agendas for the week as well. So my hope is to do it weekly. Through the automations on the dashboard, we may do it daily. But I think to really sit down and digest it and understand what to do would probably be weekly. Dr. Swain, we expect on average, yeah, so 0.5 to 1% of the population to come down with viral upper respiratory every day. So Milwaukee County, 4,500 to 9,000 tests per day. So at least 3 times higher. Oh, and then at least 3 times higher. I was going to say at least 3 times higher than what we're doing right now, number one, but also 3 times higher than that once influenza season rolls around. So we know we're not even testing all the symptomatic people. And we test a lot of asymptomatic people too. So we're not even starting to get toward that 4,500 to 9,000 in our population. And for those outside of Milwaukee County, we have about, give or take, 1 million people in Milwaukee County. Not seeing any other questions. I thank everyone for joining. I will certainly look at the list of who joined and send out the recording as well and to the invite list. But thanks everyone for joining. I'll hang out for a couple minutes in case there's any other questions. Thanks. I'm seeing a question from Chief Parrish from Milwaukee Fire Department. Opportunities for health systems and FQHC to leverage data insights. Yeah, I think so, absolutely. So when we think of our testing, there's really 2 arms to our testing. There's the National Guard testing, and then there's the health system-based testing. There are other ones. We have pharmacies doing testing, we have grocery stores doing testing, but really I think those are the 2 main arms of our testing, National Guard and health systems. And so when we talk about health system testing, our health systems did a great job and have been doing a great job continually of ensuring that there's testing centers throughout the county. But I think this can help to strategize those better. Is there an area of the county that we may not have been expecting as much that's yellow and really needs testing? Can they stand up a clinic there? So I think absolutely health systems and federally qualified health centers can use this data as well when they look to testing. Globalepidemic.org from Harvard. I am not familiar with that, Dr. Hargarten, but I'll take a look. Thanks. Dr. Colella from the Medical College of Wisconsin and the State Medical Director for EMS. How many FQHCs are in the north and central part of the city? Yeah, there's quite a few. And they've been doing a great job standing up testing. I think they also are under their capacity. So they have more tests than they have people coming to get tests. So I think it gets back to messaging, to targeted messaging, and then also to decreasing any barriers that there are to testing. Chief Lipsky, where can you get that cool background? I'll share it with you. Whoever wants the background, I'll share it. Custom built. Oh, it was private. Chief Lipsky. Well, nonetheless, I can get the background out there. Approximate numbers of asymptomatic testing, Dr. Colella, a really important question. So the challenge with that is that the WEDS database, which is the statewide database, and I know there's some folks on the state on this call, so definitely feel free to chime in. But my understanding, and Shannon and Zach are here from our data folks, but my understanding is the statewide database, when the data is input from the test being collected, a lot of times that symptomatic versus asymptomatic is not entered. Now, when our health departments go back on the positive cases and do their tracing, that's a question they typically ask is, was the patient symptomatic or asymptomatic? But that throws off and skews who we're finding the data on. So to be able to say what percentage of asymptomatic patients are testing positive, what percentage of the patients we test are asymptomatic, unfortunately, the data just isn't there to display it. We've really wanted to put that up on our dashboard because I think it'd be so informative. But every time we look at the data, it's just not, it's not usable to make it a meaningful metric on the dashboard. And I didn't mean at all to put that on the state. It's just not usable because the infrastructure isn't there when the test is first collected to ensure that everybody's writing this down. And certainly the infrastructure in there to ask our health departments to contact trace every negative case, let alone every positive case. Suspect few folks are getting randomly tested without some driver to do so. Yeah, no, I would agree. I think what the messaging has been most recently is if you have symptoms of COVID or concern for having COVID, concern is broad, it's fairly vague, but at our National Guard testing sites, that's been the messaging that we've been using locally.
Dr. Weston, this is Darren from Greenfield. I know you've looked at the data too, but I just ran it quick for Greenfield. After contact tracing, looking at the totality of all symptoms, it looks like almost a third of our people are asymptomatic. Now, I don't know how that portends on the county level, but again, you're completely right. We don't know at the time of testing if they're asymptomatic, and many people who might be asymptomatic then might have developed a symptom as we go through that laundry list of symptoms with them during the contact tracing process.
Yeah, thank you. Thank you very much. That's really helpful. Yeah, it'd be great to have it up there. I'd love to have really good countywide data. We'll circle back and see if it's, somebody asked me that again today. So we'll circle back and see if we can, if the data's improved or even more recently, if we can get it up there. Dr. Swain, testing of contacts should probably be a separate category. Probably makes yeah. So certainly, I think there are asymptomatic groups that make a lot of sense, and the state did a great job releasing new guidelines to clarify this. But certainly, definitely in place-based settings. So if you have an outbreak in a nursing home, it makes sense to test everybody. I think you can control that population, control the messaging a lot better. Positive contacts, even if they're asymptomatic. Definitely in a healthcare setting, if if a clinician and a patient have a conversation and they understand that there is risk and there should be a test, or there's some special circumstance like a surgery or something, there should be a test. Absolutely. I think where it becomes harder is in community testing. And my, I'll say my personal opinion on it is if we had unlimited tests, great, test everybody. And test them once a week, but we just don't. And not only do we have unlimited tests, but it's the whole infrastructure test. It's the lab processing. It's the tracing from our health departments. It's the entry into databases. It's all that stuff, and they're just like everywhere else in the country. It's limited resources. Director Rausch from Greenfield, difficult to tease out. Yeah, absolutely. Good point. Asymptomatic contacts from totals tested. A question from Diksham Ramnani. Are you distinguishing between general testing and outbreak testing in the model? Yeah, that's a really good question. So we haven't yet. It hasn't been. I think that'd be an interesting direction to go. I think when we're talking about outbreak, we're talking about, you're talking about like place-based. So a nursing home with an outbreak, a jail, a factory, whatever it is. I think it is hard because, and we've seen certainly in the state of Wisconsin, lots of discussion about is a factory, does it count as part of the community? Of course it counts as part of the community. Everybody in that factory works in the community. and interacts with the community. And the factory is probably essential to the community. So it certainly is part of the community. So I think it's hard to, and even a jail, you know, in theory, a jail is this isolated island, but it's not. People are visiting the jail. Guards are going home to their families. There's all sorts of ways that people are, you know, interacting in and out. So there really is no complete bubble of a facility. But that said, it might be interesting to pull out place-based testing and really just look at community-based testing as well. All right, I'll end here. Thanks, everyone. Take care.